And here is your question. Right, so if you have read and understood, considering it communication skills station, can you please begin?
Hello, I'm Dr. Mustafa. I'm calling vascular consultant, seeking for his advice and asking for accepting our case of acute limb ischemia.
Okay. Summarize, yes.
I have a 54 years old lady admitted with mild diverticulitis. That symptom improved with intravenous fluid and antibiotics. Now she is complaining of sudden onset of acute severe lower limb ischemia. On examination, ECG show AF with preventricular complex. And ABG show metabolic acidosis with hypokalemia. Arterial duplex done that confirm acute limb ischemia.
Okay.
I asking for transfer to your specialist.
Okay. Is it urgent or can you send tomorrow in the morning?
Yes, it is urgent. We can't wait for the morning for fear losing her limb.
Okay. Do you think that a consult with a cardiologist is needed?
Yes, she will need cardiologist, but her priority is her limb ischemia intervention.
Okay. What do you think about he is diagnosed as a diverticulitis?
Again, please.
Can you
Okay, what do you think of her that preserved diagnosis of diverticulitis already?
I think it's due to electrolyte imbalance.
What?
Right. Or another, any cause?
Maybe from ischemia.
Myocardial ischemia, yes. And
Okay, what is the differential diagnosis here? What is your differential diagnosis?
Maybe mesenteric ischemia with limb ischemia.
Okay, and do you think that first need to abdomen scan then transfer?
For now, abdomen is improving with IV fluid and antibiotic. She may do it later after transfer. But on examination, abdomen is soft, not tenderness, and stable.
Okay. Now, if you think that it is mesenteric ischemia, what imaging you want to do?
Again, please.
If you think that it is mesenteric ischemia, what want to do first?
I will consider embolectomy if there is acute limb ischemia or angioplasty with stent. If it is chronic ischemia or acute on top of chronic ischemia, we can do bypass or amputation if non-viable.
Do you want to add any anticoagulant?
Yes, we start with heparin unfractionated heparin with bolus 5,000 IV with maintenance dose 18 per kg per hour.
What is your management plan in this case?
Again,
What is your management plan in this case? Management plan.
Plan of what?
Management.
Plan. What are you want to do for treatment?
How would you manage the
Treat-
patient?
I will correct hypokalemia and the metabolic acidosis and atrial fibrillation for now.
Okay. Can you tell me that how you manage the hypokalemia?
I will we can consult internal medicine and neurologist, but we can start with insulin and glucose IV with salbutamol suction.
It is hypokalemia, doctor.
Yes,
Okay.
I'm sorry. We can take potassium IV infusion with slowly read.
Okay. What will you tell to her family?
I'm tell her that she in urgent case with acute limb ischemia, that's why we can transfer it to a specialty center of vascular surgery.
Okay. And how you transfer the patient to my facilities?
Again, please.
How you transfer the patient in my facilities?
With well occupied ambulance with CRB kits and blue ambulance.
Okay, you can transfer the patient.
Thank you.
Okay, you can summarize. Okay.
Yes, I can summarize that we will transfer for 55 years old lady diagnosed with mild diverticulitis that was stable and the recent complaint of acute limb ischemia now.
Okay, you can transfer the patient.
Thank you.
You still have 1 minute left. So anything that you missed, what are the other images that you'll do to confirm your new diagnosis?
We do arterial duplex that confirm acute limb ischemia, and we can do CT angiography of both lower limb.
Okay. If you have to manage acute lung injury, if there's a possible, what would be the measures that you'll take?
Measure of viability of lower limb.
Okay. I'm talking about because
about
patient,
what?
yes, because patient could also be suffering from acute lung injury.
I will involve ITU specialist with a case, and we start with measuring O2 saturation and the O2 mass.
Good. Okay. Good. Yes. Both of you covered.
The one question is miss.
Yes. Which one?
Yes, ma'am. One question miss. What are you telling to your patient family?
I said that.
You asked
yes.
Oh, okay.
Yes.
Okay.
Good,
thank you.
Good. Thank you. Here is your question. Right. So if you have read and understood, considering a surgical pathologist patient, kindly tell me what are your differential diagnosis for this patient?
This girl may be suffered from pathological fracture due to some maybe due to metabolic disease or malignant disease.
Okay. How would you confirm your diagnosis?
First of all, I would like to do a X-ray of the right lower limb
Okay.
to see the fracture and any lesion around it.
And what are the
then,
important blood markers? Yes, please.
Ma'am, I would like to do complete blood count, and then the tumor marker we can do
Yes.
CEA, carcinoembryonic antigen C125, and serum ALP, and I would like to do plasma and protein electrophoresis.
Okay. Can you please tell me? Yes. Right. Can you please tell me what you expect to see on the X-ray images that you will do, which will confirm your diagnosis?
In the X-ray, we need to find 4 things. Where is the lesion in the epiphysis, diaphysis, or metaphysis?
Okay.
And
this image may not represent the patient or the stem. Can you please tell me what you see? Can you describe the image?
This is the X-ray of lower limb, lower part of and upper part of the ankle, showing radiodense shadow in the lower end of tibia.
Okay. What is the management options or alternatives that you can offer to the patient?
First of all, we have to stabilize the fracture by external fixator or internal fixation. Then we have to find the cause of the fracture, and we have to identify the cause and treat it accordingly.
What kind of lesion can you see in the low part of the tibia? Yes. Can you how would the management differ if you knew that this is the primary tumor of the bone? Okay. Once you cannot answer, then you can say, I'll come back to this question later. Okay. Can you please tell me what are the risk factors which contribute to pathological fractures?
Risk factor, there are certain factors which predispose to pathological fracture, such as if the patient suffer from renal osteodystrophy or osteoporosis, and osteomalacia, and osteomyelitis, osteopetrosis, Paget disease, and this, and some malignancies such as primary bone tumor, and which is benign or malignant, and maybe metastatic bone tumor.
Can you, okay, can you please explain what is the mechanism or pathogenesis which lies behind this condition?
According to the X-ray, or
according to the stem, sorry. This patient has experienced this severe pain. Can you explain the pathogenesis? What patient, if you think your primary diagnosis is pathological fractures, so how the pathological fractures occur?
I think the patient may be suffering from some
tell me the pathological, in pathological language, please, in pathology language.
And when there is a malignant or benign tumor in the bone, which which causes the periosteal reaction in the bone, and also causes osteolysis, which causes the bones to tendency to fracture even in minute activity or minimal trauma. So when the patient when the bone becomes so vulnerable due to osteolysis and periosteal reaction, then in case of normal activity and in even minute trauma, there is pathological fracture
Yes.
occurs.
How bone becomes vulnerable? What is happening in the bone? Now you have to imagine, close your eyes and imagine at the bone level, osteoclastic activities has increased. What else is happening?
Yes, ma'am. Ma'am, in case of metabolic bone disease, there may be decreased mineralization and decreased bone mass, and increased bone resorption. And in case of malignancy, there is increased osteolysis, and which causes and the bone reaction. There is periosteal reaction, which causes the reduction of bone mass and increased osteolytic activity, and which causes the
Can
bones
you
become so
please
vulnerable.
tell me some secondary causes of pathological fractures? Can you mention
Secondary
few
causes,
conditions, yes, which can also lead
yes, ma'am.
to pathological fractures?
Yes, ma'am. In secondary, there is correctable and uncorrectable condition. In correctable, there is renal osteodystrophy, hyperparathyroidism, and osteomalacia. And in case of uncorrectable condition, there is osteogenesis imperfecta, polyosteitis fibrous dysplasia, Paget's disease, osteopetrosis, and postmenopausal osteoporosis.
Okay. Can you please tell me what is the blood supply of the bone?
Blood supply of the bone, there is the blood vessel enters to the in the epiphyseal and metaphyseal artery and through the nutrient foramen of the bone.
When you consider the bone structure, which part of the bone or which layer of the bone gets affected when there is pathological fracture?
And the cortical part of the bone gets more affected.
Okay. Can you tell me from outside to inside the layers of the bone, please? Periosteum. And then?
In the outside periosteum, then the cortex, where there is a Haversier system, and
Okay.
And inside there is a medullary cavity where there is bone marrow.
Yes.
And
okay. Right. Right. Thank you. Here is your question. Right. So if you have read and understood, considering it communication skills station, kindly begin.
Hello, I'm one of the surgical doctors working here in the hospital. And today I have been asked to talk regarding stopping warfarin. Sir, could you please tell me your apprehensions stopping warfarin?
Okay, Dr. Sam call me that I have surgery that's for my inguinal region swelling, but I take some drug. They say that I should stop this drug, but my previous doctor said that never stop this drug.
Okay, sir, now I'm going to tell you what is warfarin that you are taking and how it acts in our body. So warfarin is a drug which release some chemicals to stop formation of the clot in our blood. And in your cases, your doctor prescribed this warfarin because you have a mechanical heart valve. So this warfarin is preventing clot formation in your heart valve. So as we are preparing you for inguinal hernia operation, so before the operation, we have to stop this drug because it can cause bleeding before or during or after the operation. And this drug has a long duration of action. So we cannot, we have to stop it 5 days before the surgery. Are you following me that I'm telling you?
Yes, yes.
Okay,
Doctor.
so in that case, we will not leave you alone without any drugs. We will prescribe you another drugs, which is called heparin. It's an injectable one, but it has a short duration of action. It will do the same type of action. So we will prescribe you instead of warfarin. Is that okay with you?
Doctor, I have to admit it in hospital 5 days.
Yes, as the warfarin, you have to stop 5 days before the surgery. So, and after that, as I have been told you that we will not leave you without any drugs. So we have to give you injectable heparin. So during heparin, we have to monitor you by seeing the blood, and as well as we have to stop it 12 hours before the surgery. So that's why we should have to admit 5 days before the surgery.
Doctor, it's frustrating to me in stay in the hospital for 5 to 7 days. It is possible to give the drug in home?
Yes, sir. There is some anticoagulation clinic near your hospital, near your house. You can go there and get the blood test and get your heparin. And as well as the anticoagulation nurse will come to your home and can give this. But in your case, my first preference is still if you can manage to stay in the hospital. And otherwise, you can choose that options too, please.
Okay, doctor. And when I take injection for lifelong, or I can take warfarin again?
Yes, you can take your warfarin again after your operation done. When we completely satisfy that there's no bleeding, then you will start warfarin along with the heparin. And after the 3 days, we will do a blood test, and this blood test will show us whether the warfarin has regained its action. Then we will stop the heparin and you can continue your warfarin as long as you can. Is that clear to you?
Yes, doctor, my doctor said that I have to test an investigation like that INR for every month. Can I continue this investigation, or I need any, because new drug is added to me?
No, just when you will do it just before the operation, and after the operation, when you have to see the action of the drugs. You don't need to continue for every month.
Okay. And when I start to do INR again?
Yes.
Because my doctor said that I have to do INR every month, but you add new drug. So when I start again to INR?
The INR is a test which is usually done when we start the warfarin. Okay, so when we start the heparin warfarin together, after the 3 days, when we will see that INR is normal, then we will stop the heparin and you will continue the warfarin. And you don't need to do it in every month. Is that clear to you?
Yes, and doctor, I take some drug of like diazepam. Can I take the drug?
Yes.
I stop. I have to stop.
No, you don't need to stop. You can eat your antihypertensive drug at the day of the operation with the sips of water before 8 a.m. So,
Okay.
am I clear to you all the things? Can I summarize what we have been discussed?
Okay, doctor, please summarize.
So today we have been discussed about your concerning regarding stopping your warfarin. So I'm telling you the action of the warfarin, that it stops prevent clot formation in your heart valve, and as it has a long duration of action and it can cause bleeding, so you have to stop 5 days before the surgery, and it will not leave you without any drugs. We will give you heparin. It has a short duration of action, so you can stop 12 hours before surgery, and after the surgery done, when we satisfy that there is no bleeding, along with the heparin we will give you warfarin, and after 3 days we will see that the warfarin has regained its action. Then you can stop the heparin and you will continue your drugs. So I am can I convince you? Do you want to add anything, or do you want to know anything?
No, okay, thank you, doctor.
Okay, so I'm leaving my number here. If you have any concerns other than that, you can contact us. Thank you.
Okay, thank you.
Right, you still had 45 seconds left. So it wasn't quite how it should have been. Yeah, can you give a feedback first? Then I'll give mine.
Ma'am, in this station, confirm the patient name and age
Yes, and
needed.
yes, and what else is more important?
And he say I said that we start heparin. So heparin maybe need to test APTT for see monitoring that. Yes.
Yes, and
Yeah.
And
pointing,
also
yes.
INR can.
I'm pointing in the stem something. Patient is legally blind.
Legally blind, yes.
Yes.
And to home
What
stay
appreciation you have shown to the patient being legally blind, and then patient lives alone. Some little bit Dr. Shahidul Rahman changed in the stem when she was explaining about the start of heparin and staying in hospital. Patient would first say that I live alone, how would I manage it? And then she can offer that, okay, we can arrange, but then you have to arrange social services, local GP, you have to involve all those, which you missed. One thing Dr. Shahidul Rahman already mentioned, that you had to confirm the patient's identity. Second, patient was legally blind, so you could have asked, because legally blind does not mean that because it's because of cataract. He was not born blind. You could ask if the lights are okay, because patient would be wearing sunglasses in the room and will have a walking stick. So you have to show consideration. After meeting and greeting and confirming the name and ID, then you have to say, is that all right, the lighting, or is it bothering you? Then I can dim the lights. Patient, let the patient answer, no, it's okay, or yes, maybe you can dim the lights a little bit. You have to show the respect and consideration that patient is legally blind first. And then you can say, okay, I've been told you have certain concerns about a medicine that you are taking. Drug, using the term drug gives a very negative image. Drugs are the substances that we use to abuse, like urine and others, ice, etc. So drugs you will not use, never ever. Use the medication, because a medicine that you are taking, you have some certain concerns about it. Can I know the concerns? Let the patient tell you the concerns and then begin. Okay. And that in that way, you'll also be able to know at what level patient has anxiety or frustration or fear of this new drug. This was one. What else?
Okay, ma'am.
Yeah, at the end, okay, you.
I want to know one thing that he's talking about INR. What do you want
Yes,
to
he
know
was
exactly
he
about
was
the INR?
asking. Yeah, certain things, because I don't think he had prepared it very well as well, because he changed it a little bit. But you did explain about the INR. But about the staying in hospital and taking other medications, yeah, your answers were more or less right, but not the way you presented. Because I'll tell you one thing, this is very important for everyone. There'll be two examiners. One will be looking at your academic thing, what answers, academic answers you're giving. If I exclude everything that other and only focus on your answers, and I ignore the word drug, and if you have used the word medicine instead, then
Yes, ma'am.
your answers were okay. But the more important, the other examiner will be looking at the way you convey your information, how sympathetic you are to the patient. If you're using layman language enough for the patient to understand, because some of your answers, like that was gain or something, or yeah, once you were explaining, you were not explaining in the layman language, like an elderly patient, legally
ma'am.
blind, that language you have to use so that patient can understand it. But then you were asking, am I clear to you? Are you following me? Okay, you were checking up on the patient. If patient is following you, or if you and patient are both on the same page, this is very important. But then the way you take the patient, yes, the communication and everything, that is also very, very important. People fail on those grounds.
Okay.
So we'll practice.
Okay, ma'am.
We'll practice.
I say that patient, I take warfarin, and my doctor give me advice to follow up every month to test iron at that level is normal or not. But you advise me the heparin. So your answer is maybe like that, and you follow me as APTT. Should be 50 to 60 because you start heparin. But when you stop heparin, then you can I can follow up as INR for next month.
That is
Like that.
with
Okay.
yeah, that is with the test, because when you add a new medication, you have to explain that new way of following up that new medication as well. So that you could have explained. You'll practice. We'll improve. Because I did not say that it was.
Ma'am.
Yes, please. Yes, Dr. Ima.
Ma'am, if the patient is blind,
yes,
should we touch? Should we ask him that, can I touch your hand, or can I touch your back, so that we will see, show more empathy to them?
Touching, they don't appreciate. Physical context, they don't appreciate.
Okay.
But then,
okay.
yes,
in case of blind man, how will we
Yes, this is very tricky, because once you enter the room, maybe just the tip of the shoulder you can, or and then you can extend your hand, and because you don't even, because this is the post-COVID era, you can't even extend your hand, but you can sit in front and you can make them, because there is many ways. Like once you are greeting, and you don't have to touch. Touching, they don't like, and I would not recommend. Even shaking hands, they don't like it because of the transfer of the viruses, and this is post-COVID era. So you can still make the other person realize that you're talking to them. And once you'll confirm the name and age, and then the person will know that you are talking to the person. And if you'll ask, if the lighting is too much, should I dim it for you, if it's bothering you, then you are showing empathy, and you are
ma'am.
If anyone else has any views, they can definitely add. And here is your question. Right. So if you have read and understood, considering its surgical anatomy station, kindly tell me if you can identify the images. If we begin with the left-hand side image, can you identify the structures from A?
This is a digital subtraction angiography. Structure on the right, on the left of the screen. B is the internal carotid.
Okay.
And then A is the anterior cerebral, and V is the middle cerebral.
Okay.
C, I think, is insular or okay. I'm not sure. Okay. F is.
What is carotid angiogram? If you can explain it to me.
What?
What is carotid angiogram? In which conditions? Yes. In which conditions would you ask for yes carotid angiogram?
To assess the patency, circulation.
Okay.
Sure that
can you please tell me the course of internal carotid artery?
First, the internal carotid artery has only one branch outside of the cranium, which is the ophthalmic artery.
Okay.
Then it enters through that's the cervical internal carotid, and then there's the cavernous, and then first there's the.
Okay. Can you please tell me about the blood-brain barrier? Are you there? Are you there? Can you hear me? I can't hear you. You got disconnected. Can you tell me about the circle of Willis?
The circle of Willis.
Okay. Yes, please. How circle of Willis is formed?
By anastomosis between the vertebrobasilar system and the internal carotid branches.
I'll ask you about the image afterwards. If you can just tell me what are the vessels which form the circle of Willis?
Can you hear me?
Now I can. Can you tell me the vessels which form the circle of Willis? Okay, can you tell me if there is infarct of middle cerebral artery? How would patient present? Can anyone else hear?
Yes, we can hear me.
Okay, I can't.
No, we can't hear.
I can't hear
Also-
anything.
I think she has problem in network.
Network
We can
problem.
hear you.
Yeah. So what are the signs of middle cerebral artery infarct? How would the patient present? I think he got disconnected. Yeah.
Patient can
Anyone else
present
want to
with,
answer? Yes, please.
Patient can present with contralateral hemiplegia or hemiplegia on both the upper and lower limbs. Patient can also present with facial nerve palsy and also aphasia.
Aphasia, okay,
Dominant.
on the dominant hemisphere, and hemiplegia of the lower half of the face. Okay. Can you tell me the course of the vertebral artery?
Vertebral artery, it begins from the first part of subclavian artery, and then it travels up and it travels in the foramen transposterior of upper 6 cervical vertebra. And then when it traverses the first through the foramen transposterior first, then it arches behind the posterior arch of cervical 1 vertebra. Then it enters into the cranium through the foramen magnum, and then it joins the opposite sides, opposite vertebral artery to form the basilar artery in front of the bones.
Okay, good. Yes, if we can come back to this image, if you can identify all the structures, A to F, please. This image is important.
A shows there's a dilated artery that's looks like middle cerebral artery. Aneurysm of middle cerebral artery.
All right.
B is the
I guess. A is internal carotid.
Internal carotid.
Oh, yes. Internal carotid, yes, sorry.
Yes.
B
And
is
B is
anterior communicating, C
yes.
is intercerebral,
Yes.
G is intercerebral, and E is basilar, F is posterior cerebral.
Posterior communicating. Okay. What is Barry's aneurysm?
Barry's aneurysm is just the abnormal dilatation of the cerebral arteries.
Middle cerebral artery.
The arteries forming the circle.
Okay, this Barry aneurysm is associated with another condition in the person or patient. What can that be?
It's usually associated with polycystic kidney.
Yes. When there is a rupture of Barry aneurysm, how the patient presents?
Barry's aneurysm can present usually rupture of Barry's aneurysm will lead to subarachnoid hemorrhage.
Yes, and the rupture is spontaneous. It does not have to be associated with trauma. Right.
Yes.
What should be the plan of management? Okay, Bell has gone. One more slide I think I have. This arrow is pointing at what I've already asked you. It's the Barry aneurysm. If there is any more, yes. If anyone can, this also image is very important. If anyone can, there is 1, 2, 3, and 4. If anyone can, please describe. What is this one?
I think it is unilateral internal carotid artery.
Internal carotid artery. And what is this? It's MCA. This is also MCA.
Yes. Yeah.
And this is ACA. Good. Thank you. Question. Right, so if you have read and understood, considering which history taking station, kindly begin.
Okay. Hello.
Yes.
So
Yes, you continue.
Okay. Hello, I'm Dr. Meem, one of the exam candidate today. Could you please confirm your name and age?
Mr. George, 57 years.
Okay, so nice to meet you, Mr. Mr. John. Yes,
John.
nice to meet you, Mr. John. So, can you please tell me what is the problem today of you, and how can I help you today?
Okay, I have a pain on the lower part of the tummy for 3 months, doctor. So that I come to the hospital.
Okay, so I'm very sorry to hear that, but I think it is troubling you very much. So now I want to ask you a few questions regarding your problem so that I can help you in your diagnosis. So, so you have said you have pain in your tummy for 3 months.
Yes, doctor.
Okay, so exactly which side? Can you please tell me?
And it is like in the left side of my tummy. Left side of my tummy.
Okay, did it started suddenly or gradually? Okay, so can you please describe this pain? Like, is it throbbing in nature or bulky in nature or whatever it is?
It's like doctors like a throbbing type of pain.
Okay, so is it travel anywhere in your tummy or your to your back?
No, doctor, it's fixed on the lower part of the tummy.
Okay, so is there anything which makes your pain worse or better?
No, doctor, I think not so.
So in which time, is there any timing of your pain, like in the morning or evening, your pain increase or decrease?
No, doctor, there is no timing also.
Is it constant all the time?
Yes, it's constant and every time some pain.
Okay, so can you please score it if I give you a scale from 0 to 10?
Okay, it's about 4 to 5.
4 to 5. Okay, so you have mild to moderate pain. So can you please tell me that is it associated with any swelling
Some
or
pulsatile pain, maybe it is like some moving to my left side of the tummy.
okay, so have you any history of fever?
No, no fever.
Okay, so is this so you say that this mass has a pulse, so is there any skin change overlaying the mass or overlaying the pulsatile swelling of your tummy?
No,
Any
nothing.
discharge from
No, no
this?
discharge.
Okay, so have you any history of trauma or
Sorry, doctor, I
have you
cannot.
any history of trauma at your tummy or like taking an injection?
No, doctor, but I have a little bit trauma about 3 months back. But after treatment, I am purely
Okay, so
recovering.
have you any other in any side of your tummy beside
No,
this? Okay,
no, I think not so anything.
okay, so is this swelling is reducible or present in constant in nature?
I think constant in nature.
Okay, so so you have no fever, you said. Okay, so
Yes.
you have okay. So now I want to ask about your past medical and some surgical and family and social history. So have you any medical illness before?
Blood pressure.
Okay, so in which drug and what is the frequency and in which dose? Can you tell me?
Okay, it's called amlodipine. I take it in the morning, but those cannot remember.
So
Doctor.
have you any surgery in your past?
No, I have no surgery.
Okay, so so you've taken medication only antihypertensive or anything other?
I cannot remember, doctor.
So only you just only take this amlodipine, right?
Yes, yes, doctor.
Have you any allergies to any the drugs or these drugs?
No, I have no allergy.
So any of your family member with the same clinical problem, or can you remember?
Can you summarize your history now, please?
My grandpa maybe have.
So ma'am, my patient, Mr. John, 57 years of old, presented with the history of pain at his abdomen, in the left abdomen, left lower left abdomen, and it is associated with the pulsatile swelling, and he has no history of fever or any skin change or any discharge, but he has history of trauma.
Yes.
3 months back, and he's a patient of hypertensive. He's a patient of hypertension, and for this he's taking amlodipine, and
So what are your
there is no other lump.
So what are your differential diagnosis?
So considering this is his presentation, I think it is a case of pseudoaneurysm.
Okay. How would you confirm your diagnosis?
I'll confirm this diagnosis by angiogram.
Any other investigation? Irritography has already been done. Anything else? Okay. What are the treatment options that can be offered to the patient?
So at first, as he has pain, first I'll give analgesic. Then after consultation with a vascular surgeon, after vascular surgeon, a endovascular coiling can be done for this aneurysm.
Can you define the term false aneurysm? Can you tell me what is
the aneurysm which has not all the 4 layers of blood vessel? Yes, ma'am.
Yes. Okay. As compared to true aneurysm, what is true aneurysm? Layers are 4.
Sorry, ma'am, I can understand. Can you please repeat?
What is true aneurysm?
Three layers.
Yes.
True aneurysm, which has 3 layers of all the 3 layers of blood vessel.
So what are the 3 layers of the blood vessel from inside to outside, please? Tunica intima.
From inside to outside, these are tunica intima, tunica media, tunica externa.
Adventitia or externa. Okay.
Adventitia.
Oh, tunica adventitia. Yes.
And here is your question. Right. So if you have read and understood, considering it clinical examination session, can we begin? Can you begin?
I will enter the room, wash my hands, get to yes. I will
Can
enter
you-
the room, wash my hands, greet the patients.
Yes, and
Hello,
begin.
I'm Dr. Muhammad, I'm the surgical doctor. Today I have been asked to examine your knee. Are you okay with that?
Yes,
Thank you. Can confirm your name and age, please?
Peter, 21 years old. Yes, continue.
Okay, nice to meet you, Peter. I will expose the patient on for that. I will ask the patient if I will ask the patient if do you have any pain at the moment?
Yeah, slight pain.
Okay, I will try to be gentle with you. Okay, if you have any thought, stop me at any time. Okay.
Okay, please go ahead.
I will start with normal knee. Okay, I'll start by feeling the temperature. Then for any tenderness. Meanwhile, I would like to look at the eye patients looking for any grimace. I will start by palpating the tibial tuberosity, then by manual palpation, then patellar ligament, and then for the patella and joint line, I will shift to the right knee, looking for any tenderness as well. After that, I will flex the knee at 90 degree and also start to palpate for tibial tuberosity and joint line, and also posterior looking for any Baker cyst. Okay. Now I will move to. Can you just flex your knee? I will ask the patient to flex his knee and then do the put his right knee in the left and for vice versa. Okay, I would like to ask the patient to abduct and abduct his knee. Then I will move to the passive flexion of the knee and also right and the left, both of them, and also abduction and abduction of the legs. Then I will look for the special test. I will start by posterior saxine. I will lift the right knee at 90 degree and support with the Achilles tendons with my right hand. Then flex the knee at 90 degree. Then I would like to do the anterior and posterior draw test gently at the edge of his foot, and then pull the tibia anteriorly and posteriorly, looking for any abnormality at the anterior and posterior cruciate ligament. Okay, then after that, I would like to do the Lachman test. Okay, I will flex the knee at 30 degree. And, my right hand, I will try to move the tibia, and my left hand on the quadriceps muscle. I will move it, and after that, I will doing the Mcmurray test. I will support the feet with at my elbow and internal rotation and external rotation of the knee. Then I would like to do the valgus and varus test. Okay, I will support the feet with my elbow and then apply varus force, looking for any medial or looking for lateral cruciate ligament, or then valgus force, looking for the lateral cruciate ligament rupture. Okay. Thank you so much. You can just if you need any help.
No, thank you. Can you please describe this test? Still have time.
Yes, 6 seconds. 5.
Which test?
Yeah, anterior means.
Okay.
The draw test.
Summarize.
How you would ask what you would ask the patient to do? How you would
Open yours,
manipulate?
yes.
Oh, the bell has gone.
Yeah. Can you summarize your examination, please? Can you summarize your examination, please?
Yes. Today I have examined 21 years old. Yes, I have examined 21 years old male who present with pain in his right knee. On general inspection, there is smoke in his urine. His anti-gate is normal in comparison to both knee. Bulge and butt, right? Which test is positive